Welcome, everyone, to our first of 3 educational opportunities hosted by the Minnesota Rare Disease Advisory Council on the topic of genome newborn sequencing. I'm so glad that so many of you could join us today. Welcome. The Minnesota Rare Disease Advisory Council is a executive branch state agency, and our goal and our mission is to provide education and advice and training around issues related to rare diseases. So we're very excited for this learning opportunity. Before I turn this over to our moderator and our panel, I just want to go through a few logistics with all of you who are joining. So the first thing is we will have presentations followed by some question and answer time, some Q&A. Please put your questions in the Q&A, not the chat, so that our moderator can see those and so that we can get those asked of the panel. So please use the Q&A feature, not the chat. In addition, we are recording this so that we can send it out afterwards. So this is a recorded session, just so you all know. Today, we're joined by an amazing panel and amazing national leaders in the space of genetic sequencing. And also, I just want to give a shout out to Anastasia Friesian. She is our wonderful aspiring medical student. She has a degree in genetics, and she's going to be doing the logistics of the meeting. So thank you so much, Anastasia. So now I'm going to turn it over to our moderator, Amy Givligio. So Amy is a recognized expert in the field of genetics, and she has a strong background in public health and in rare disease policy, and is just an absolutely brilliant. So I'm so happy that she's moderating today, and I'm going to turn this wonderful presentation over to Amy.
Thank you, Erica. Can you hear me okay? Can you guys hear me okay?
I can hear you.
Okay, perfect. So thank you, Erica, and welcome everyone. And thank you so much for joining us for today's educational webinar focused on genomic sequencing in newborns. So as many of you are already aware, this is a timely and exciting and nuanced topic, and we are looking forward to beginning this conversation and providing the forum for discussion here in Minnesota. So today we will focus our time on really setting the foundation of what we mean when we talk about genomic sequencing in newborns, sometimes referred to as genomic newborn screening, and learning from 3 other programs that have already embarked or are embarking on exploring this technology. Next slide. And sorry, Anastasia, for some reason I can't see the slide, so I'm just going to have to say next slide. But first, I would like to introduce you all to our working group, which is hosting this webinar today. So our Genomic Newborn Screening Working Group was formed with the mission to foster understanding, connection, and informed dialogues around genomic newborn screening in Minnesota. And through inclusive education and transparent engagement, we hope to position Minnesota to lead the nation in ethical, innovative, and family-centered approaches to genomic newborn screening. This group is made up of a collaborative group of individuals across the state representing numerous relevant organizations. And we have just launched our website, which you can access here via this URL or by scanning the QR code. And definitely we invite you to stay connected or get involved. And next slide. So as I indicated at the beginning, the topic of genomic newborn screening is complex and nuanced, and there is absolutely no way we could cover everything in an hour today. So this is really just the start. We are already planning 2 additional events on this topic coming forth in January and February. And again, using that QR code in the corner, invite you to stay connected for updates and invites when these dates and times are finalized. I will note that the 3rd event, the one held in February, will be in person at the University of Minnesota, and we'll quite excited to bring everyone together for some more kind of face-to-face discussions. Next slide. So before I turn to our truly incredible speakers today, I do want to provide some foundational background. And the first centers on terminology. It is really important for us to think about genomic newborn screening in the context of, but not a replacement for, traditional public health newborn screening. So traditional public health newborn screening is the successful population screening program that has existed in Minnesota and in the US since the 1960s and operates at the public health level. Here in Minnesota, as is true in many other states, it is administered by the Department of Health under a quasi-mandate or opt-out model, meaning that this screening occurs by default with parents having the option to refuse or opt out of the screening if they so wish. Public health newborn screening relies on a legal doctrine known as parens patriae to operate under this kind of quasi-mandate opt-out model. And this doctrine essentially grants the state the authority to act in a child's best interest to protect them from harm. In this case, the harm of not having an early diagnosis of an otherwise treatable congenital disease. In order for diseases to be added to newborn screening panels, they must meet certain criteria, including things like having a good test and having an effective pre-symptomatic treatment. On the other hand, when we talk about genomic newborn sequencing or genomic newborn screening, as of right now, this is currently being done more in a clinical and hospital setting. It involves informed consent of the family to choose to have this level of testing and often relies on other concepts like medical guidelines or ideas around clinical actionability and utility when we think about what diseases to include. And as a result, owing to both the technology, so whole genome sequencing, and this kind of differing policy approach, genomic newborn sequencing or genomic newborn screening has the ability to detect a much wider range of potentially actionable childhood diseases. Next slide. And the premise of newborn screening and genomic newborn screening lies in its ability to provide early identification of rare diseases long before they would otherwise be clinically detected. So on the left, you can see the typical rare disease patient diagnostic journey in the absence of things like newborn screening or newborn sequencing. The journey usually begins with the onset of symptoms, which are usually nonspecific and hard to pinpoint, and this is followed by numerous medical visits with the primary care provider, Dr. Google, often several specialist visits. And research shows that this journey, or this odyssey, can take 3 to 5 years before a correct diagnosis is made. And this typically comes at great financial, emotional, and health costs to both the family and the medical system. In many cases, this process takes so long that the child is no longer able to benefit from treatment options or participation in clinical trials. But if we look at the same journey on the right, in the presence of newborn screening or genomic newborn sequencing, we can see that this affords us a clearer look at those babies who are deemed to be at higher risk through screening and immediately get them into the diagnostic pipeline. And this typically leads to a correct diagnosis in days to weeks rather than the several years we often otherwise see. Not surprisingly, this opens up treatment availability and in some cases may open up clinical trial options. And so this is the premise that underscores both public health newborn screening and the potential use of genomics in newborns. Next slide. So as we further consider the use of genomics in newborns, it is also important for us to understand that this too can mean different things. So this graphic shows the spectrum of use of this technology in the neonatal period. On the left, we have the use of what we typically call rapid whole genome sequencing for those babies who are in a special care unit, a NICU or PICU. This is now largely kind of considered a standard of care as we have a sick infant where we are trying to figure out what is going on. This is considered a diagnostic application of whole genome sequencing. And in Minnesota, through statute, we do provide coverage of this testing really as a result of understanding its importance in providing quick answers for our sick children in the state. On the right, however, are kind of what we would consider screening applications of this technology. And this is because we are using this technology in newborns right away before symptoms start, so in seemingly healthy newborns. And even in this realm, there are 3 possible ways to think about it. The first, so on the left, is what we would call a reflex test. This is potentially integrated into newborn screening programs where we would do our usual kind of biochemical level screening and then use whole genome sequencing after to focus in on those genes or areas of the DNA that correspond with our biochemical findings. The second potential use is what I'm going to call targeted whole genome sequencing. So this would be a first tier or frontline application. So this testing would be done first or right away. And it generally is looking at a list of anywhere from 100 to 1,000 genes that lead to child onset diseases. And then on the far end of the spectrum is truly looking at the whole genome. So all of our genes, no matter what we know about them or when the disease onset might occur. For the purpose of what we are talking about today, we are talking about the application of targeted whole genome sequencing. And this is how nearly all research programs have been examining this technology in newborns. Next slide. And there are actually quite a few genomic newborn sequencing projects worldwide, well over 30 at this point, spanning North America, Europe, Asia, and other countries as well. And so we are really well poised here in Minnesota to learn from these projects, which is exactly what we will be doing today. So that brings me, next slide, to our incredible speakers, and I will introduce all of them right away so that we can kind of move through their presentations seamlessly and then take Q&A at the end. So our first speaker will be Dr. Melissa Wasserstein. Dr. Wasserstein is a professor of pediatric and genetics and a Raisin Distinguished Faculty Scholar in Pediatrics at the Albert Einstein College of Medicine. A board-certified biochemical geneticist and pediatrician, Dr. Wasserstein diagnoses and manages individuals with inborn errors of metabolism. She directs NIH-funded research activities focused on expanding newborn screening, enhancing its accuracy, and evaluating the practical and ethical implications of expansion through exploration of parental perspectives. Our second speaker is Dr. David Ledbetter. Dr. Ledbetter is at FSU, Florida State University College of Medicine, where he continues his NIH-funded research on the genetic basis of autism and related neurodevelopmental disorders. He is a graduate of Tulane University and earned his PhD at the University of Texas, Austin. He is an internationally recognized expert in genomics and precision medicine, having discovered the genetic causes of Prader-Willi syndrome and Miller-Dieker syndrome, and focusing his ongoing research on discovering the genetic causes of childhood neurodevelopmental disorders, including autism. He has been a pioneer in the translation of new genomics technologies into clinically useful genetic tests for early diagnosis and intervention. And finally, we'll hear from Dr. Mike Yu, who is a genetics researcher and a parent of 2 children with a rare disorder. He is an ardent advocate for newborn screening and focuses on using genomics to address the critical need of expanding the public health newborn screening program. Mike is the co-founder and treasurer of Project Guardian, a nonprofit organization with the mission of advancing genomics-based newborn screening. So thank you all so much for being here, and I will turn it to you, Dr. Wasserstein.
Thank you so much, Amy, and I'm very honored to participate in this important discussion about genomic sequencing newborns. So I'm going to start by providing some insights from Screen Plus, and then I will introduce you to the Beacon study. Next. Here are my disclosures. Next. And similar to Amy, I'm going to start with some basic definitions that I found helpful when discussing newborn sequencing because the terminology can be a little confusing. So I think it's going to be helpful if we're all on the same page. So diagnostic testing versus screening. Diagnostic testing is used to look very specifically for an underlying cause of a condition. And examples are an MRI if you have knee pain, a biopsy if there's concern for a tumor, or rapid genome sequencing for a sick baby in the NICU to try to learn why that child is so sick. Screening is used to screen a presumably healthy population for disease risks, and examples include mammograms, cholesterol checks, and our routine newborn screening. Can you click again? So genomic newborn screening, where does it fit in? Well, it's the concept of using genomic sequencing as a screening tool in a presumably healthy population to assess disease risk is conceptually really different than its current use in diagnostic testing. So it's very exciting, as Amy had pointed out, but this also raises a lot of questions that we will start to analyze here. Next. So our current newborn screening system is a routine newborn screen uses analyte and physiologic marker based analyses. And what that basically means is that it looks for a phenotype or something that's physically abnormal, such as an elevated phenylalanine level to predict PKU, a low GALC activity to predict Krabbe disease, or abnormal hearing. Many and most newborn screening programs are actually using second-tier testing, including sequencing of specific genes to enhance accuracy. And the program is built so that there's a low false negative rate so that babies aren't missed. If we turn over to the reddish color, those are some of the negatives about our current routine newborn screening system, in that we can only screen for disorders that actually have something we can measure, an analyte or a physiologic measure. There's complex assays, instrumentation, and training, and there is a high false positive rate where a lot of babies are referred to follow-up programs and then end up not having the disorder. Next. Genomic newborn screening is currently being used in a research context. Amy had pointed out all the programs across the globe that are, again, are research-based programs. So it's being done as research because, again, there's evaluated. The benefits shown in green are, first, that there's no need for an analyte. You can theoretically screen for a limitless number of monogenic disorders, and it ultimately may be more cost-effective than our current multi-assay-based routine newborn screen. But there are some concerns and questions. And can you click? The first is this high potential for uncertainty. First, we have let's start with this concept of genetic variants of uncertain significance. And for the non-geneticists, we obviously all have differences in our genomes from one person to the next. Most of these genetic changes are not disease-causing. They just kind of make us unique and different from one another. A variant of uncertain significance is a genetic change that where there's just not enough information to know if it's a disease-causing change or just a regular change that makes us unique from one another. Diagnostic genetic testing, it's estimated that anywhere between 20 and 40% of results have variants of uncertain significance. And when you also consider the concepts of reduced penetrance and variable expressivity, meaning that many, if not most, genetic diseases present differently from one person to the next, and maybe even within a family they can be different, there's potential for a lot of uncertainty with genomic sequencing. Other concerns include the genetics, the genetics workforce, which we know there's not enough genetic counselors and medical geneticists, the role of informed consent in sequencing and scaling that to meet a population-based program, and big issues with DNA data security, storage, and safety. And some of the earlier studies did show a high false negative rate. Up to 40% of babies may potentially have been missed in these early studies who ended up having a disease. Next. Thank you. So I'm going to turn to Screen Plus, which thank you, is a consented pilot newborn screening study. We are working with the New York State Public Health Laboratory. We're enrolling babies up to 4 weeks from 8 high birth rate hospitals in New York City. The first goal is to assess the accuracy. We are an analyte-based multi-tiered program, and we're screening babies for a fluid panel of treatable disorders. The second goal is to evaluate the disease progression in pre-symptomatic infants identified through the program. And the third is to examine some of the complex ethical, legal, and social issues associated with screening babies, and we're using a series of surveys and parental interviews. And we've been doing this for a while. Under the name Screen Plus, we've actually had, I think we had almost 37,000 today. We had 5 years of a previous pilot newborn screen for LSDs, which didn't have a name, but in that program we enrolled over So we've recruited, consented, and enrolled a lot of babies into newborn screening programs, and have handpicked for today's very brief discussion a few snippets of Screen Plus that I think are relevant to today's discussion about newborn sequencing. Next. So first of all, as I mentioned, we've consented and recruited over 100,000 babies, which of course is relevant to the discussion about genomic newborn screening. And the way we work in Screen Plus is that we have active recruiter-assisted recruitment, information giving, and consent, where the recruiters speak with families on the maternity wards face-to-face and follow up either through email or text or phone or MyChart. And these, again, are recruiter-assisted. We also have a fully passive model where parents can see some of the study information through brochures or posters, scan the QR code. Looking on the bottom left, can you click? Click. Oh, thank you. The majority of parents have told us that these direct discussions with the recruiters were the most helpful decision-making tool. And click again, please. And then this bears out when we look at how our parents ended up consenting, with the vast majority using recruiter assistance and very, very, very few consenting on their own. Can you click again? So this is our first lesson from Screen Plus, is that enrollment in pilot newborn screening programs seems to work best with direct interactions with recruiters. Next, please. We built in parental perspective surveys, so anybody who's approached to participate in Screen Plus is also invited to partake in these surveys. I'm going to share with you a little bit about some of these. The first one is about expanded conditions, when we asked parents who screen for disorders with variable ages of onset and questionable treatability and uncertainty. We asked about the role of informed consent, and we asked parents about their trust in various entities. So this is lesson number 2. It really is important to have empiric data from these key stakeholders, meaning parents, to help guide newborn screening expansion, including sequencing, in a transparent manner. Next. And I'm going to share just one result with you because it highlights parental opinions about screening for disorders that have uncertainty. And I mentioned before that uncertainty is a concerning issue in genomic newborn screening because of VUSs, penetrance, and expressivity. And just to orient you, the blue figures on the left represent parental responses about if they'd want their own child screened, again, specifically for conditions with uncertain prognosis and diagnosis. And on the right, in green, we think informed consent should be required. Can you click, please? Click, please. So if you look on the left, almost over a quarter of parents would not want their own child screened in cases of uncertainty. And on the right, in green, almost half of them think that informed consent should be required in cases of uncertainty. Can you click one more time? So this is lesson number 3. Do your best to minimize uncertainty, especially if you're doing genomic sequencing. And in the meantime, make sure you get informed consent. Next one. We asked about parental trust, which again is an issue in genomic sequencing, given the complexity of the data that will be stored. Most parents, 74%, trust medical researchers, 62% trust state public health departments, and it cuts down to 56% when we asked, do you think that state health departments can actually protect privacy? Can you go again? Click. Next. Thank you. And then when we asked them what can enhance trust, most of them showed that it is actually just transparency. One more click, please. So this is lesson number 4, that it's essential in genomic sequencing to be transparent with parents with respect to data and sample storage and privacy. And can you go one more time? Okay, now I'm going to transition to beacons. And I'm sorry I'm going so quickly, but there's a lot to cover. But I did want to make my transition slide a shout out to Logan Spector and Michelle Rosler, who actually repurposed our Screen Plus dried blood spot surveys and shared it with fairgoers at the Minnesota State Fair this summer. Can you go one more? So now introducing you to Beacons. Beacons is a newborn screening by whole genome sequencing collaboratory research project funded by the NIH Venture Program. The overall goal of this feasibility of developing a collaborative model to allow incorporation of genomic sequencing as a first-tier screening tool for select monogenic diseases that are actionable in the first year of life into the existing state-based U.S. public health newborn screening programs. And I highlighted some of these words because this is not a program to see how many babies you can get in and how many babies you can screen. It is really focused on, will this work within the context of our current public health-based newborn screening program? It's a feasibility study, so that's the data that we're looking at, is feasibility. It's a 3-year-long milestone-based project that will enroll up to 30,000 infants from about 7 states with different degrees of readiness and different geographic locations to help evaluate the impact of genomic newborn screening on the workflow of state public health laboratories and to identify and address concerns. And the project is guided by a community advisory board, as well as an NIH, NBS, and WGS working group. I put the pseudo logo on the right. This is not our actual logo, but I put it here just to remind myself this is a work in progress because we've only got the notice of award about 2 months ago. So we are currently running at full pace to lift this like behemoth of a project and get it running. So I can share with you what I can share with you, but we don't have a whole lot. Oh, I think I made myself clap. Okay, next, please. So our study design for beacons, again, this is 36 months. This is lightning speed. We, in the first 6 months, and again, have just finished month 2, we have established our community advisory board. We are creating the protocol. We're engaging with our public health laboratories, and we have chosen 7, and they will be notified within the next several days. We are undergoing legal review, starting focus groups with parents and public health laboratory and as well as creating our gene list. And all of these things need to go before our CAB and our NIH partners. We are hoping to start recruitment in our first most ready state, approximately 6 months in, which will be in early spring. During those first 6 months of recruitment, we are using our partners at Ariadne Labs, who are implementation scientists, to do PDSA cycles to help us learn quickly what's working and what's not working, so that when we go to full-scale recruitment in the fall with all the states, we'll be ready to go, and hopefully it'll run as smoothly as possible. We will be recruiting prenatally, postnatally in 2 major hospital systems in each state, as well as passive recruitment, so that any baby born in the state during the study period will be eligible to participate. You can see in the light teal color on this slide all of the LC work that's going to be done. There'll be interviews with the healthcare providers. There'll be interviews with, obviously, with parents and families, and there'll be a lot of interviews with the public health laboratories to learn about what's working and what's not working. And again, the whole thing is governed by CAB and LC input. Next, please. And the study flow from recruitment to return of results is shown here. Again, we'll be recruiting prenatally, postnatally, and passively in each state. We'll get consent, which will be an e-based consent, sample collection, which will use the existing dried blood spot that had already been collected for newborn screening. We'll take 8 punches out of that, but there'll be no additional sample necessary. The public health laboratories will be doing the accessioning and prepping and punching the samples. They'll be transported to gNBS, which is our sequencing lab for beacons, who'll do DNA extraction, sequencing, variant analysis, and orthogonal testing when indicated. And then the results will be shared back with the public health, working with each PHL to see how they're currently sharing results of routine newborn screening. And again, this is a feasibility implementation study, so our goal is to have the PHL share the results with babies who are positive, with a lot of support from the Beacons team. If you look on the very bottom of the slide, we have a GRC, which is the Genome Resource Center. So for those public health labs with less readiness, who might need a little bit of help and talking points and a little bit of, more education about how to address this, we will be there and ready to support. We're also creating act sheets for each for the people returning the results, as well as for families. And then follow-up care will be the specialists in each state who are tasked with following up that child. Next, please. And my next few slides are just to show you how large the Beacons team is. There's a whole lot of academic medical centers across the country, gNBS, EPIC, the HL has been critical and central to helping us choose the public health laboratories and all the consultants from the institutions on the bottom. Next. Here's one page of the Beacons team. Next. Another page of the Beacons team. And next. Another page, and I just wanted to, of course, embarrass Amy Gaviglio, who, along with Natasha Bohmholm, are co-chairing our community advisory board, so they have a critical role in this project. And then next, and then just thank you to my Screen Plus team, the Beacons team, and then one more slide, please. And then any questions, and shout out again to Logan for sharing this amazing butter sculpture with me. So thank you.
Thank you so much, Melissa. I think we can move to Dr. Ledbetter now.
Yeah, thanks, Amy, and thanks for the opportunity to talk to you today and tell you about our ambitious plans in Florida. We don't have any data to show yet because we're planning to launch our newborn sequencing project early in 2026. Next slide. I just want to emphasize that everything going on in Florida is the result of one person. That one person is Adam Anderson, who is now a state of Florida representative, but is a business person in Tampa, Florida, who's also the father of a rare disease child. He and his wife, Brienne, lost their son, Andrew, to Tay-Sachs disease 5 years ago. He and his wife became very passionate about how to improve pediatric rare disease state throughout Florida, meaning earlier diagnosis, earlier intervention and treatment for those diseases that have treatments, and stimulate research to discover new treatments for those that don't yet have any treatments available. So Adam Anderson decided that he could be most effective in the state of Florida by entering politics and ran for the House of Representatives and was elected in 2022. And shortly after he entered the House, was able to get an initial allocation of funding to create the Florida Institute for Pediatric Rare Diseases at Florida State University. I left out a slide at the last minute. I'll tell you a little bit about the functions of the Institute. It has a clinical, educational, and research mission. Because we're an educational institution, we're starting a new master's degree program in genetic counseling. It's already been alluded to that we have workforce needs related to implementing genomic medicine, including newborn genome sequencing. Personally, I think genetic counselors are the key to most genomic medicine implementation. There's only one master's degree program in the state of Florida. Based on our population, we should have 3 or 4 training programs. So we hope to launch one at Florida State in Tallahassee by 2027. We also are developing a clinical genome sequencing diagnostic lab at Florida State University to serve North Florida region and our own healthcare system. We're building a new Genome First pediatric clinic where we will order clinical genome sequencing on the first visit to shorten the diagnostic odyssey and to make patients in Tallahassee and North Florida able to get local genome sequencing and diagnostics from genetics without traveling to Gainesville 2 hours away or Jacksonville 3 hours away in order to do that. We're developing a gene therapy research and vector core and funding research pilot projects, currently just for Florida State University faculty, but eventually to make it a statewide research pilot project program. The biggest project, as listed here, which was enacted July 1st of 2025, it's called the Sunshine Genetics Act and creates a statewide pediatric genetic network that will include University of Miami, University of Florida, University of South Florida, Florida International University, which is near Miami, and major hospitals in the state. This is coordinated by our team at Florida State University in Tallahassee. We'll design and implement a pilot study on genome sequencing of 100,000 healthy newborns, screening probably for about 600 rare genetic conditions. I'll come back to that and tell you we haven't finalized our gene condition list compared to the current 60 conditions in the state of Florida's traditional newborn screening. As commented on by Melissa, this will be a full opt-in consent mechanism. And we hope to begin recruitment, consenting, and sequencing in early 2026. Representative Anderson would like to see us start in January, and we're working hard to see how close we can come to that ambitious goal. Next slide. We benefited from the fact that there are a number of ongoing studies with a lot of experience that we're able to learn from. This is a sample of 6 genomic newborn screening projects in the US and around the world. Some of the enrollment goals of those studies when the program launched. So several of these have been around for 2 to 3 years at the moment. And then just the number of genes and conditions ranging from about 230 to 400 in several cases and 4,000 in the case of BabySeq. Next slide. And you just heard from Melissa, the newest study funded by NIH now called the Beacon study that will be finalizing its gene list soon and partnering with, as you heard, 7 states. Florida is intending to closely watch and closely emulate and collaborate with the Beacon study. So there's a good chance that when they finalize their gene and condition list, we will adopt that as our core so that we can compare our data directly to theirs with perhaps a small number of additional genes added to that core. Next slide. I'm not sure if it's been mentioned today, but there's a great international consortium on newborn sequencing, originally founded by Robert Green and David Bick, now in the UK, that has a monthly Zoom meeting that's very informative and has updates on pilot projects and working groups, and just had its 4th annual meeting in London, October 23rd and 24th. So 2 of us from the Florida Sunshine Genetics group were able to attend and learn from the groups that have been ongoing and have lots of lessons learned to pass on to us. So they have a fabulous website as well. So anybody interested in this topic should join as an individual or institutional member and try to attend the monthly Zoom meetings. And the annual meeting next year will be back in the US in Boston. I don't remember the specific dates, but maybe others will later. Next slide. So our group has met as a steering committee to plan the protocol and talked about at what point should we recruit. As you've already heard, some groups are doing patient education, recruitment, and consenting prenatally, some at birth, and some during pediatric well baby visits. We would like to start patient education and consenting prenatally, and then confirm the consent at birth. But we will probably also do some pediatric well baby recruitment as well. Next slide. How should we consent? You've already heard good descriptions again from Melissa about different strategies. We plan to put a heavy emphasis on digital platforms, chatbots, and tablets, and e-consenting, as alluded to previously, as being key to being able to scale to universal genome sequencing on a statewide basis over the next several years. Next slide. And sample collection, we plan initially to piggyback on the existing dried blood spot. So in the state of Florida, they collect 7 spots, and we can get punches from one of those spots would be sufficient for whole genome sequencing. So on our steering committee, we have the newborn screening laboratory directors from the Jacksonville lab and from the newborn screening follow-up program in Tallahassee involved as key partners in planning our statewide pilot project. Next slide. So it was interesting to me when we sat down to think about our gene and condition list to look at the rationale for selecting medically actionable disorders at different ages across the different studies. I show here examples from Guardian and the Generation study in the UK. And the next slide shows a similar summary from Early Check in North Carolina, Baby Seek in Boston, Beginnings, Rady Children's Hospital, and Baby Detect in Europe and Belgium. Most impressive is the next slide, which shows if you make a Venn diagram of the overlap of genes between different pilot projects, and shown here is Guardian on the upper right in green, Generations in the bottom in the purplish color, and Early Check in the upper left in the yellowish brown tan color. You see that there's some overlap, but not a lot of overlap, and there are only 99 genes that are present in all three of these pilot projects. And if I added more newborn sequencing pilot projects, you would see this Venn diagram get increasingly complicated with relatively modest overlap between the genes and conditions that have been chosen to date. Next slide. This is another summary showing that if you look at a consensus across these 6 genome newborn screening projects, there are 69 genes. If you look at the overlap of those 69 consensus genes to the RUSP newborn screening panel, you see again a modest overlap of about 47 genes and conditions in that comparison. So there's a tremendous amount of heterogeneity across pilot projects. I'm sure at some point in the future, there will start to be a harmonization of the criteria for adding genes when we're doing whole genome sequencing, and we have the choice of looking at thousands of genes if we had the workforce person power to report those results and do appropriate clinical medical follow-up to those. But right now, all of the pilot projects are characterized by extreme diversity across the different pilots. Next slide. So like all other pilot projects and like ICONS, we've developed working groups to help us sort through the decisions to be made, and that includes a patient education, recruitment, consenting. Tara Randis is a neonatologist and head of neonatology at University of South Florida in Tampa, which will likely be our first hospital recruitment site. A gene condition list, which is chaired by Pankaj Agrawal, who's head of neonatology at University of Miami, previously at the Broad Institute and Boston Children's Hospital, and a strong genomics background. A community advisory board chaired by one of our patient advocates, Dorothea Lance, very active in the state of Florida and nationally with rare disease advisory committees in different states and many different rare disease advocacy groups. An LC and health economics group chaired by Jeff Brosco at University of Miami, and we're borrowing Hadley Smith from Boston, who's agreed to give us advice and help us organize our health economics, but also broader LC considerations in our study. And a data governance, data and informatics committee led by David Seo, who's the chief informatics officer at Nicholas Children's Hospital in Miami, and a clinical program, follow-up program chaired by Amaris Sanchez Valley, a metabolic geneticist at University of South Florida and one of the state newborn screening follow-up program directors. That may be my last slide. I checked. Yes, that was my last slide. So again, we have ambitious plans, but just organizing and learning as much as we can from all of the existing pilot programs. And just to comment, they've all been wonderful about sharing their experiences with us and trying to help us get started in Florida. Thank you.
Thank you so much, Dr. Ledbetter. And I hope everyone is starting to hear the trend of how complex these programs really are. You know, it's much more than just doing the testing. It's all that goes around, wrapping around, making sure that the families can benefit from this testing, and how important it is for us to learn from each other, because there are just so many different ways to tackle this. So with that, I will swing it over to our final speaker today, Dr. Mike Hugh. Mike, floor is yours.
Thanks, Amy. Thanks for inviting me to join this very important topic. I am going to give you an introduction of our study, the Guardian study, which stands for Genomic Uniform Screening Against Rare Diseases in All Newborns. As the slide shows, the slides are borrowed from Dr. Wendy Chang, our principal investigator, who was at Columbia University in New York and now serves as the chief of pediatrics at Boston Children's. So what I'm going to be showing you today are data from the New York study. Next slide, please. As the topic suggests, we screen babies with sequencing for genetic diseases. The workflow goes as follows. We approach the expecting parents in their third trimester visits to give them information about the study while they have time and energy to think about participation. We approach them for in-person consent during the newborn period. And once we get their consent, we work with the state lab to retrieve the remnant dry blood spot samples that are used for routine newborn screening. And so no new samples are taken. We use those samples to isolate the DNA, do whole genome sequencing to targeting on about 450 genes. And as Amy mentioned initially, we do whole genome sequencing, but we'll only look at these genes. So it's targeted whole genome sequencing, as she calls it. We typically get the results within 3 to 6 weeks, depending on how successful the sample flows through. And for the positively identified babies, we initiate their treatments, interventions, what have you, as indicated by the chart. Next slide, please. The conditions screened meets certain criteria. We choose to have early onset serious diseases to be included. The median age of onset is before the age of 5. And we choose to have variants to report that have high penetrance. This, in simple terms, is once you find the variants or changes in the DNA, these variants have a high likelihood of showing up on the babies to have symptoms. You click again. We separate our conditions into 2 groups. For group 1, this is for all the participants. As soon as they enroll in the study, they will get screened for all of group 1 conditions, over 300 conditions. These are typically metabolic disease, cardiac disease, immunodeficiencies, and they all have readily available treatments. This can include as simple as dietary treatment, or it can be medications. In some cases, it can be procedures, including bone marrow transplant. And all of these conditions have confirmatory testing available for diagnosis. Group 2 is a little bit different. This group has 144 conditions at the moment. These are typically neurological conditions that affect development, and many of them involve patients experiencing seizures. And so for this group of condition, the things we can do are a little bit more limited. These conditions don't have readily available treatments other than seizure control, early intervention, which are important but different from group 1. Many of these have ongoing clinical trials, so as a way of intervention, we can refer the parents to clinical trials. With regard to confirmatory testing, they're a little bit more variable. Some of them don't have very good confirmatory testing, so the confidence we have in the final diagnosis would be a little bit lower. it's important to point out that we have this designation of group 2 conditions in many ways in preparation for flipping them into group 1 when it's ready. So once we show we can accurately diagnose these diseases, and when the clinical trials are successful, we have treatments available, we can change them into group 1. And because we're doing whole genome sequencing already, the data is there, the change will just be more of a digital switch, so make it a lot more streamlined. Next slide. To give you a glimpse of what we have, this is showing the first 10,000 babies we have enrolled and screened. And at the moment, we're close to the 20,000 mark, but the general conclusion is about the same. Within the eligible population, these are all the parents going through those hospitals that we're running the clinical studies at. We were able to approach about 60% of them. And within those we approached, 74% of them enrolled in the study. And so this is an encouraging number, meaning a majority of the parents are in support of the study. The type of consent we have are mostly in person. You can see a small fraction of remote. These are the parents who didn't consent in the newborn suite and wanted to think about it more and were consented afterwards via phone or email. Ancestry makeup mimics well the local population. And I want to point out on the lower right corner, the group 2 consent rate. As mentioned, group 2 are optional conditions that the parents can choose to be tested or not. And also, certainly because group 2 conditions are different from group 1 in that they are quote unquote less actionable, if you will. There's no drug-based treatment. It's encouraging to see that forget about the separations in ethnic groups. The overall enrollment in group 2 is 92.6%, meaning over 90% of the parents, when they enroll in a study, they want to know all the information. So this shows the desire of the parents of the current generation. Next slide. I won't bore you with all of the details with the research. We have published our initial findings in the Journal of American Medical Association. So you can find that, or you can contact us later on to find out more. Next slide. I do want to show you a couple of cases just to illustrate how the study has been working. So the first example is from a group 1 condition. This baby has X-linked severe combined immunodeficiency, or SCID. It's a serious disease, typically causing death within the first year of life without treatment. The condition, importantly, is included in the standard newborn screening. But for this baby, the standard newborn screening assay turned out to be negative. It's a normal result, so missed by the standard newborn screening. We found the variant that are tagged as likely pathogenic, and we did literature research to see that it has been reported before to be associated with serious disease. And we went out with the diagnosis, which is confirmed by confirmatory assays. And so as follow-ups, we initiated infection prevention for the kid to prevent potential life-threatening infections before we were able to do the bone marrow transplant, which was successful. And the baby, who's a toddler now, has been doing very well. Next slide. Second example is a group 1 condition that is not on the current newborn screening panel, the standard newborn screening panel. It's a cardiac condition called long QT syndrome 2. This has pediatric onset, and the cumulative mortality is 6 to 8% before the age of 40 years. So it does have consequences down the road. And we identified this patient and confirmed the diagnosis using traditional EKG. So the baby does have a longer interval between the Q and T peak on the echocardiogram. The follow-up is we introduced beta blockers for the baby, which is a set of very safe medications that are recommended for these patients. we instructed the parents to avoid medications that can prolong the QT or increase the cardiac risk. And the follow-up with pediatric cardiologists has been ongoing, and the baby is doing fine so far. Next slide. Finally, an example of a group 2 condition. So this is a condition that is not being screened on the standard newborn screening panel. The baby has what's called a Rett-like syndrome, developmental delays, and certainly seizures involved. There's no family history. So as a follow-up, when the diagnosis was made, the baby was already symptomatic, and an anti-epileptic drug has been initiated. Based on the diagnosis, we switched the baby to a safer drug and more effective drug with regard to the syndrome itself, and referred the baby to early intervention program. Next slide. One thing we wanted to know, which is very important, is why the 26% of approached parents choose to decline the participation in the study. And this is because for a long time, one of the prominent worries for genomic-based newborn screening is that people are going to be concerned about privacy, about genetic information, genetic discrimination. And so in our decline surveys, what we found out is most of the decliners actually have very simple reasons to decline. They're either not interested and with no other reasons provided, or they think the standard newborn screening is enough, which are the top 2 bars. And then if you look down the list, the privacy of genetic information and particularly genetic discrimination are very low on the list in terms of the respondent rates. So I think it's encouraging to see that this is the response from the current generation parents, which are the population that this clinical study and the eventually implemented public health program intends to serve. So understanding what they're thinking about is most important and relevant, and we're seeing encouraging signs that the parents wanted the information and they're not as concerned as we thought they will be on the other privacy concerns. Next slide. We also followed up with the parents with their potential decision regret. This decision regret scale ranges from 0 to 100, where 100 is extreme regret and 0 is no regret. What we can see in the middle panel is for the babies who screen negative, the parents have very low, basically baseline level of regret. And for the babies who screen positive, those families have slightly increased, but still very mild regret. We drilled down into the screening positive families and separated them into group 1 and group 2. On the right-hand side, as you can see, group 1 parents and group 1 conditions are certainly the ones that are treatable immediately, have lower regret compared to group 2. As mentioned, group 2 don't have readily available treatments, most of them. And so the regret scale did increase. Furthermore, if you click on next, we looked at their response over time. So what you saw just now, which is shown on the bar graph on the left, by and large, are the results from right after returning the newborn screening results to them. And on the right-hand side, we did another survey for the same parents after the baby turns 1 year old. So what you can see is for all the groups tested, especially for group 2, which is the blue bars here, the regret decreased over time. And we think that is a good sign showing us that the parents are recognizing that even though there are no direct treatments available at the time of screening, there are value in having the results, whether it's knowing that the disease, being able to avoid diagnostic odyssey, being able to talk to the providers about the diagnosis so that they can have more targeted treatment plans and responses. Parents are finding that these tests are actually valuable and have lower regressions to participate. Next slide. This has been a study that's carried in a couple of central hospitals. And so obviously, in order to scale it to statewide public health program, there are many steps to be taken. I want to just point out that this is where a state-based pilot program, as you know, for example, the Minnesota state is thinking about right now, can have advantages because the scaling up steps, every state have small but critical differences in regulations and infrastructure and how things are done. So if the pilot program can be done with the mindset that these scaling up tasks are going to be requiring certain ways of doing things, those can be implemented effectively and tried out during the pilot period. Next slide. Next slide. There we go. So hopefully I have conveyed to you that we have a high uptake from the parents about genomic sequencing-based newborn screening, and they're by and large satisfied with the study. It's important to point out, and I think in this regard, both Minnesota and the other studies are sharing the same. It's important to get the communities involved early on. We similarly have a community advisory board, meets regularly and meeting with the study team regularly before and during the study, so that we can ensure that the way the study is conducted, the way the consent is being done, the way the follow-ups are being done, matches what the parents of the current generation wants to see. And I think the encouraging results show that these are important efforts to be put in upfront. So, and then we've also shown that we can identify pre-symptomatic newborns using sequencing, and we can initiate treatments for them for better outcomes. And here, importantly, this has been shown to have synergistic effects with standard newborn screening. We can complement and improve on the results together with the standard newborn screening. It is feasible so far on a modest scale, and scaling up is certainly one of the required issues required to be addressed in the next few years. The results, currently we can return them within 3 to 5 weeks. We think with appropriate scale at the end, 10 to 14 days can be expected. And finally, just want to say, we in the study have a channel of nominating new diseases from the community, and this adds to the importance of the group 2 conditions, where if we have conditions that are not really ready for the prime time for group 1, we can try it out still, and when time is right, it's a digital switch, pretty simple to make them group 1 conditions. So it makes the program elastic and expandable at a minimum effort. Last slide. These are all the team members who participated in the study, and of course, this only lists key contributors, and just wanted to highlight that it is totally a community effort. We have the treating physicians, we have nurses, the study team, we have biotech companies, pharmaceutical companies. We work closely with the State Department of Health and their newborn screening lab. We work with the community, including parents. And so I think as it has shown to be a successful effort as a community-based approach, I think future studies hopefully can adopt that and make it a continued success. Thank you.
Thank you so much, Mike. And I just want to, before turning it over to Q&A, want to thank all of the speakers again. This was incredibly helpful and informative. And so I know there are several questions in the Q&A section, and I will now turn it over to Dr. Logan Spector to moderate the Q&A.
Thanks. And I'm Dr. Logan Spector in the Department of Pediatrics at the University of Minnesota. Thanks for all the questions. I guess I'll start with one for Dr. Ledbetter, and you partially answered this talking about paying attention to your workforce needs with genetic counselors. But the question is, what steps is Florida taking to ensure that newborns identified through the Sunshine Genetics Project are able to access needed specialists, diagnostic testing, and treatments after screening?
Yeah, that's a great question and a big question. And we're just beginning to figure out as I said, my starting point is genetic counselors, but then we're also starting to work on how to recruit and retain more pediatric geneticists, neurologists, and other pediatric specialists, particularly in North Florida and the Panhandle, which is a particular desert for those pediatric specialists, but it's a statewide problem like it is most every place. So we don't have a good solution yet.
I suppose I should ask Melissa if the Beacons Project has thought about workforce preparation or how these results get handed off to, the clinicians that ultimately will take care of the children.
Yeah, well, we have this is a feasibility study, so we're not supplying the specialists, but we're relying on each state to have their own team of specialists. And we've actually done a lot of work in choosing the states. There's been a lot of back and forth with states who have expressed interest to make sure that there are specialists in neurology, genetics, whatever it may be. But again, it's a feasibility situation. So if there aren't enough geneticists, that kind of reflects real world. So we will be having training for people who are not geneticists to learn how to interpret and share those results when need be.
Thank you. And I'm sure that this audience will want to know whether Minnesota is being considered among the states. I'm sure you can't reveal whether Minnesota is one of them.
I can tell you it's definitely being considered, and I'll leave it at that. And
Okay.
again, there'll be notifications coming out soon.
Great. So another question, I think, for Dr. Hu and Wasserstein. Both of your projects have done a very good job of working with the state newborn screening program. How have you ensured that your projects and program remain collaborative and complementary to existing newborn screening? And Mike, why don't you take that one first?
We work closely with the state lab to ensure that, we included a couple of current standard newborn screening conditions on our panel purposefully just to cross-check. And for most of the conditions, we actually don't include on our panel. And the couple includes SCID, which is kind of fortuitous. And we have worked with the state lab where when they have a unresolved case on their end, they approach us for the genetic testing results. Overall, I think it's key to keep in mind that at the moment, it is a clinical study. We are at best complementing the public health program. It remains in the research space before moving forward. And so it is critical to remember where we are with regard to the technology, with regard to the limitations, and working closely with the state lab can ensure that we are not bringing unnecessary or undue harms to the participating parents.
Great. I have a number of questions that kind of converge on the theme about N of 1. So it is certainly possible that genomic newborn sequencing will identify kids with a clear, variant that will, lead to a phenotype, but it's not been part of the panel's, decision to add to the panel. How do you anticipate dealing with that, or are your studies able to deal with the N of 1 that will inevitably come up? I guess we'll start with you, David, since you're have to start your study by January 1st.
Yeah, I mean, we're not prepared at the moment to deal with that situation, so we're just trying to get all the parts in place to start catching up with an existing gene list. Again, as I said earlier, probably using the Beacon's final gene list as our core so that we can compare data directly to them. But
Thanks. Melissa or Mike?
Yeah, I mean, I'm not a big fan of the N of one. I think that it makes things a lot more complicated, but I know that, for example, with metachromatic leukodystrophy, which is one of the disorders that's on Screen Plus, we didn't find anybody in our study so far, but we will be adding it to New York State because we're taking advantage and listening to and cooperating with some European studies that are screening for MLD. So I think that for this N of one, if it continues to be a requirement, the fact that there are so many international programs about sequencing right now, that it might not be that each individual program needs to find that one, but as long as somebody does and we're all talking to each other and sharing data, I think that that will empower everybody and empower the whole movement going forward.
Yeah, I echoed those. And outside of the newborn screening research study, I'm a fan of NF1. But within the study, I do want to say, what we do, we haven't encountered that situation yet. But what we do is through the nomination channel, anyone can nominate a new disease to be screened. And this ensures that we are looking at the current landscape. There are certainly things that we're missing, but also it gives us the chance to have rigor in looking over and examining what conditions we are going to include in our next iteration, so that we can make sure they meet all of the criteria that we have, rather than just have a disease that has an N1 success and just blindly add them.
Thank you. We have one question here that is specific to you, Dr. Hu. On your regret assessment, did you find more regrets in parents in group 1 or group 2? Can you recap that? And then I'll have a follow-up question about the parents, if you don't mind.
So the trends are fitting what we were anticipating. So first of all, in the screening negative parents, the regret scale is lower than screening positive ones. The screening positive ones, between group 1 positive and group 2 positive is higher. And then finally, after a period of time, in this case, after a year, we haven't had enough data from our 2-year yet, but from the 1 year compared to newborn time period, all of the regression scores decreased. So this is, I think, kind of intuitive, but it's also telling us that with time, people are accepting that the sequencing-based newborn screening is bringing value to them.
And my follow-up question is this. Do you think that most of the questions about that researchers or clinicians had about parental acceptance have been answered adequately by your studies or the other ones going on? And I noticed that somebody just asked about the UK's plan to move to universal gNBS in England. I wonder if that means that they've answered the questions about parental acceptance to their satisfaction. So really my question is, have the first wave of pilot studies answered those questions about parental acceptance, do you think, thoroughly?
I think there's a whole lot more work to do in this realm. Every study has a different population, and I think you learn when you're doing surveys like this that how the question is worded, what's brought in can bring completely different answers, even though you're trying to get to the same point. So I think there's a lot more that needs to be done. In Beacons, we're doing it. In the Generation study in the UK, they're doing it. I think that there are different uptake rates in different studies. So Guardian has done an incredible job. It has a really high consent rate, which is a little bit of an outlier compared to some of the other international studies. So I think we need to learn what is holding back people from those other studies. So there's definitely a whole lot more to learn in this field. And I think it's key. If the parents don't approve, we're not going to really get off the ground.
I definitely agree with that. I think the current data, we do have quite a bit of data from, all of the studies around the world now, which is rich to dig into. And I think it's showing a encouraging sign, a trend, if you will, that parents, the current generation parents, are more acceptable to this idea compared to some of our worries. But at the same time, especially in the US, we know we're such a mixed culture and mixed ethnicity group. And from the very small window that we can pick into in the New York study, we have seen the consent rate being different between different groups. And so I think it's definitely critical to drill more into that and make sure what we bring forward as a public health program eventually can fit all of the groups' needs in there and not overlooking some groups.
Thank you. We're at time, but I'll answer this last question myself, which was how can patient advocates get more involved with gNBS research programs? I think that ICONS has a space or is making one for parent-patient advocates, and I'd say that's the place to start. With that, I'd like to thank MNRDAC for organizing this. I'd like to thank our speakers for making time out of their busy schedules to tell us what's going on. And I'd like to thank Amy Gaviglio for being our moderator. We will have 2 more sessions, tentatively January 15th as a webinar and February 12th as a live event, possibly at the Wilder Center. And then Erica asked me to note that in addition to the 2 educational sessions in this series, MNRDAC will be hosting monthly Project Echo sessions. They're focused on clinicians and will provide a community of practice related to providers who care for children that have been identified through newborn screening or whole genome sequencing. More information will be posted on that series within the month. So thank you, everybody, and only 2 minutes over. I consider that a win. Take care.
Thank you.
Thank you.